It now gives patients who live in areas where they don't have access to incredible clinicians, and now they have access to a care system that was built for everyone, right? And so you can take patients who live in very rural areas, and we do a lot of great work out in New Mexico in maternal health deserts, where there's like a 3-hour drive to the closest gynecologist. And so, we were seeing patients who, prior to us initiating this program, would become pregnant, and then the next time they would see a clinician was when they were giving birth.
Hi, I'm your host, Maddison Bezdicek, VP Strategic Vendor Services at Captive Resources. This is Captivating Health Insights. Jason, welcome. Thanks so much for being on the podcast.
Thanks so much for having me, Madison. It's great to be here.
Well, this is one of our first episodes. Super excited for you to be one of our first guests. Would love to dive in and learn more about you. And I want to say your name right. I'm going to get this right. Jason Chirichigno.
You nailed it.
Awesome.
I've got many things over the years, but you just nailed it.
Awesome. Yeah, tell us about your background, Dr. Jason Chirichigno, and just about your journey.
Thank you so much. Yes, so I am a board certified, nationally licensed internal medicine physician. So what that means is I take care of patients that are 18 and above. I've been practicing for almost 15 years now. I spent the first 10 years of my career in like traditional brick and mortar primary care at a place called One Medical. And then about 5 years ago, before the pandemic, I realized that the medicine we were delivering was fantastic, but I really want to be able to really reach out and expand and take care of a much broader section of the population. So I moved to what we call a digital medical practice, a company called Galileo.
Awesome. And I would love to hear more about Galileo for those people that may have not heard of Galileo specifically yet.
Yeah, absolutely. So Galileo is what I think of as really the first ever digital medical practice. So it takes what we think of traditional telemedicine, and we'll probably talk about this later, and kind of turns it on its head a little bit and really focuses on establishing primary care relationships for longitudinal care. The type of care when we think about high blood pressure, diabetes, the care that really needs relationships moving forward. And then we add a little spin to that. We bring in specialists as well. So that way, when you come to us, we can probably handle 90 to 93% of things that you would need without having to send you out back into the, to see someone in person as well.
That's awesome. So let's talk about kind of this evolution of telehealth, telemedicine as we know it. Help us understand what the difference between legacy telemedicine and this virtual medical practice that Galileo is.
Yeah, I think that's really, really important, and I want to first say that when we think of traditional telemedicine, it's really important, and it's done an incredible role over the years. It really helped improve access. But when we think about traditional telemedicine, when I think about it as transactional care. Mm-hmm. You go ahead, you wake up, and you have a sore throat, Madison, and you know what? Oh, I have access to traditional telemedicine. I call in, I speak to a clinician who's doesn't know much about me, but just knows what the concern is going on at that moment. So it's really, really transactional. Mm-hmm. And so where I see the evolution, and I think is so critical, is establishing that relationship. That relationship that I had in the office for all those years now comes into the virtual world. And so that way, when you call in with your sore throat this time, I understand that I know, and I'm not saying this is you, but I know that you have diabetes. I know that you have hypertension. I know that you have 3 children. I know that you're struggling in this area right now. And I can always put that in the context of everything that's going on and take better care of you. And we'll talk about how this really translates down the road into things like less testing, less ER visits, less urgent care visits, because we have that relationship, we have that nuance, which really helps people put their trust in digital medicine. Even though at first it might take some time, like, can we do everything digitally? And we'll walk through how we can do that. But that's really the big difference for me, is the move from transactional care, when we think of telemedicine, to truly longitudinal chronic care with relationships.
That makes sense. So it's still like you have a primary care physician, you're established within this relationship just digitally, mm-hmm. like you would any other kind of traditional in-office primary care doctor, but now you not only can do kind of reactive care, it's treating the whole person when they call in for something else.
Yeah, no, you make a great point. It's can be reactive, but it can also be preventative too. So we think about it 2 ways. So when I think about patients that come to us at Galileo, I think about 2 things. One, if you have a great relationship with your primary care doctor out in the community, I'd never want to take that away.
Okay.
Like, that's the key to all these things. But I want to be a support, And this isn't the fault of the traditional primary care doctor. I was a traditional primary care doctor
Right.
for 10 years. The issue is this, by the time I left for medical, there was a multi-month wait to see me in the office for things like physical exams, all right? Yeah, you can see other providers as well, but you really sometimes want to have that relationship with the individual provider. This is the key. So if you have that great relationship, we can be their support. Many times a patient will come into Galileo, they know they have us as a benefit. They still have their great PCP, but they can't get in to get their blood pressure medication refilled over the weekend per se. So we'll go in, we'll ask you how you're doing, we'll get all of your history, we'll figure out your medication, we'll fill that medication for you on a Friday night or a Saturday. Then we'll get that information back to your primary care doctor. So that's kind of one wing of it.
Okay.
The second piece, like you mentioned before, we would love to be your primary care doctor. We want to get to know you and do things like your digital annual wellness exam. We can talk about that later. We really pioneered kind of getting to know all the things about your history, all the things about your family, all the things about lifestyle. And then very important, you mentioned all the preventative care, things like cancer screenings, breast cancer screening, colon cancer screening, cervical cancer screening. That's really the key, especially if I'm sure we're going to talk about at some point, really thinking about forward-thinking employers, making sure that their employees are really doing as well as possible and that we can prevent things from happening in the future.
Got it. I read a stat the other day, and I didn't really realize this. I knew that telemedicine skyrocketed during COVID, but I didn't realize that it was the average before COVID was under 1% telemedicine users, up to 80% at its highest after COVID onset, and now it's back to like 10, 15.
Okay.
What would you say is kind of sort of the greatest trend that you're seeing, the growth areas in telehealth, telemedicine as it kind of sits today in 2025?
Yeah, I think it's a fantastic question. I think there are a few really positive aspects of this movement and then some that we should really kind of keep an eye on. So for me, the most positive movement is the ability to improve access. I mentioned this before, like I'm licensed in all 50 states and Washington, D.C., so I see patients from everywhere. Now, I happen to live in a city like Los Angeles, which has a lot of access to medicine, but when I'm taking care of patients in rural Minnesota or rural Idaho, there are people who don't have access to doctors within 30 minutes, 45 minutes, an hour, 2 hours. So the first really important trend is the ability to pair access with quality. And we'll talk about how we do that in terms of providers who have 10 years of clinical experience, how we work as a collaborative team, how I have access to specialists as well. But the key then is building that relationship longitudinally, as with virtual being like the first point, because one, it's going to make things easier for the patient. Okay. Two, it's going to decrease costs. And three, it's going to make sure really that the patient gets taken care of when they want to get taken care of on their time, in their modality. We can do things like a simple phone call. We can do a video visit on the phone. We can do text-based. That's the key. When a patient realizes, that it's not when my appointment's open in the office, it's really on their time as well. Then the second trend, which I'm not as positive on, there's a ton of movement in telemedicine, for very specific conditions, whether that be erectile dysfunction or whether that be for weight loss. I want to view the patient holistically.
Yeah.
I want to know, is there something else going on that's contributing to their weight gain? Is there something going on contributing to their erectile dysfunction? So it's hard to do that when you isolate all these individual pieces. I'm sure we've kind of seen that out in the media right now. Companies just dedicate to specific things. I step back and say, hey, let's form that relationship. Primary care being the key to your longevity, the key to your health span. So that's my view on that.
Yeah, and so you mentioned access. It is amazing. You're not just limited to your, you live in LA, patients that can come see you in LA. Now you can see anyone in the whole country. So there's so much more access now for people and on their own time. Like you said, how do you control quality? What does that kind of look like as far as the quality piece goes now that the access is better?
Yeah, quality is so important. And you might have heard me say this in the past, but I'm tired of telehealth and digital medicine, really just patting ourselves on the back for improving access. Of course, if you move out from a brick and mortar office, in a big, large urban area to a cell phone, you're going to improve access. But you have to pair access with quality. That's the key. So for us, when we sat back at Galileo and thought about it, we said, hey, this really starts with the clinician, right? So I'll give an example. Starting day one post-residency, I was really excited, but you probably didn't want to see me day one, day two, maybe even month 6, even when I'm practicing. But now that I've been a clinician for almost 15 years, you start with a clinician who has a ton of experience. I think that if you're really going to be able to do great digital medicine, you have to have had that experience in the office to really know the difference in things. And it's funny, a little quick anecdote. One of the very first things you learn in medical school is that medicine is about 90 to 95% the story. Okay, the relationship is critical, and the physical piece at times is important when you have to do procedures, but so much of what's going on for you really is in the intricacy and the details and the nuance of the story. So I think, we're taking clinicians who are fantastic, who have all this experience. Then you change the way you work. So think about it. If you came to see me in the office, a couple of years ago, we probably have a 12-minute appointment, at most 15 minutes, and you walk in, Maddison, what brings you in today? It's a fantastic question to start the conversation, but when you're doing things digitally, with some degree of asynchronicity, on the patient's time, they put a case in, I can review that case, prepare that case. We work in a collaborative environment. I can say to my colleagues, I have Maddison here. This is going on. I think it's this. What do you guys think about this? And then we give each other that feedback. And I'll give you another example. I work at night. I see patients for 2 hours, 7 days a week. When I sign back in tonight, someone's gonna say to me, Jason, because this is a culture we've built, I see that you saw Maddison today. You did A, B, and C. Have you thought about D? And can you tell me more about why you did C? And now, that's not to micromanage providers or anything like that. It's really just to give the highest level of care to a patient. It's as simple as that. Then you take the ability, when I was working in the brick and mortar world, if there was a case that I was 70% certain on, 80% certain on, I'd probably send you to a specialist out in the community. And depending upon where you live, that specialist might be available a couple days from now or a couple months from now. So really important that we now have the ability on our platform, I can now turn to our infectious disease specialist and say, again, I have Maddison, I think this is going on. I'd like to prescribe this medication. I'd like to prescribe it for 7 days. Dr. Kerr, our infectious disease specialist, can come back to me and say, Jason, you got the condition, you got the medication, but you might have missed this paper that just came out a few weeks ago that says you can actually treat for only 3 days and not 7. Now, I know that might sound small, but there's so many variables there. One, you're decreasing the amount of medication a patient has to take, so you're improving compliance. 2, you're decreasing any chance of side effects, and you're gonna get the same outcome. So that's the difference in digital medicine. When you have the experience and you have the support staff, you can really do great stuff.
So it's this team approach, you as the primary care physician and then specialist. Most people don't think of specialists when they think of telemedicine and telehealth. So could you give us some examples of the type of specialists? I mean, you gave one with the infectious disease. What other kind of specialties? Because that's great because you're keeping that all within the digital healthcare the system of Galileo. It's not you're not sending them out. Like you said, you kind of keep them in the care. No,
it's really critical. And just to make a distinction, we haven't figured out how to do this quite yet, but this is all anytime we talk about specialists, we're talking about knowledge-based specialty, right? So when you need your colonoscopy, I still need to send you out to someone in person. When you need your mammogram, but the ability so many times in primary care in the brick and mortar world, when there's just a question you're not 100% certain on, you then send the patient to an office specialist. They have to then tell their story over again and again.
Right.
Things can get lost in translation. They're missing work. They actually then have to pay another copay. Now I can tell your story, Mass. I can say, any specialty, pretty much all of them, whether it be cardiology, endocrinology, neurology, outside of things like physical therapy as well, and orthopedic surgery, I can now say, hey, Dr. So-and-so, this is what's going on. What do you think we should do here? Or this is what I would like to do. Do you agree or disagree? And that way the patient doesn't have to tell the story again, and I can go back to the patient and get them that information.
Awesome. So we talked about access, quality. Let's talk about cost reduction. How have you seen telemedicine and specifically this virtual healthcare practice reduce overall health spend for employers?
Yeah, I think this is what you're going to see to be the biggest evolution. We start talking about that evolution from traditional telemedicine, which is just transactional, where the clinician on the other end doesn't know everything about the patient. If you look at the studies with traditional telemedicine, you're going to see actually at times an increase in cost. The reason why that was going on for so long was because you get someone on the phone, you don't know them very well. If there's even a hint of uncertainty, you're probably going to refer them out. Now, changing that model from traditional telemedicine to what we're talking about now, advanced primary care, the digital medical practice, what we do at Galileo, I now can go ahead and do a few things. I know you very well. I know your family well. I know that you don't need to go to the emergency room with that symptom. That someone who doesn't know you will probably send you. So let's start at the beginning. We're decreasing emergency room visits. That's critical, right? Because so much of what goes on in the emergency room is not needed. It's because people don't have access to primary care. It's because people don't even know that they can do this in primary care. They assume that the emergency room is there for that. Also, we saw over the past 10, 15 years, an incredible increase in urgent care services. And while that can be an amazing resource to the community, they're also very expensive. They bill as facilities. They almost bill at a level of a hospital. Now I can do that for them. Right? Then the point we mentioned before as well, the intricacies of knowing a patient. I'll give you an example. Take a diabetic patient, for instance, and we kind of check in with them kind of on a regular cadence, like every 3 months. They can check in with us anytime they want, but we have kind of standard check-ins every 3 months. Month 3, they're doing great. Their numbers look good. We get blood work. Month 6, the same. Month 9, those numbers have bumped quite a bit. Traditional telemedicine might just reflex to increase that medication. We're going to step back and say, Maddison, is anything else going on in your life right now? I might send you what we call a mood rating scale to check for anxiety, to check for depression. Maddison, I can't tell you how many times we find that underlying anxiety. We find that underlying depression. So guess what? I don't have to increase that medication for their diabetes right now. We take the next 3 months. We dig in on lifestyle. They weren't sleeping well. We work on sleep habits. We work on sleep hygiene. They weren't eating as well as possible. They're having some trouble with their children in school. If it's at the level of medication, we could start that medication for anxiety or depression. If it's not, we get them in one of our therapy programs. So that way, come month 9, we don't have to increase that medication or add an expensive third medication. So it's those little things to decrease costs. Well, it's going back. The big things like ER and urgent care, and then the small things like not prescribing another medication, and then also, like we talked about before, not sending you out to that specialist, because specialists are always going to bill at a higher rate, and we can keep that on the platform.
And managing their chronic conditions, it sounds like, too, with your diabetes example, but are there other chronic conditions as well?
Yeah, no, any and all of them. Blood pressure, going back to mood stuff as well. Anxiety and depression is something that really takes an enormous toll on people's ability to go to work, to, the increased costs for everyone. So even if you're not managing anxiety and depression, you're going to have people being seen for other things that might actually be related to the anxiety and depression, but they're being worked up for something completely different.
Jason, let's talk about data a little bit.
Yeah.
How does virtual primary care integrate with other systems? How does data sharing work? All that kind of technical data.
Yeah, let's just make a broad statement to start. We can talk all day about doing great stuff, but we have to make sure that we really understand that we are. And data really is that avenue. Now, of course, people are the most important thing, but data is the numbers behind it to see what's going on. So first and foremost, we have an amazing team. Now, I'm a physician, so I'm not the data person, but I talk about enough people. And so first and foremost, we have to understand who we're taking care of. So ingesting data, if you're talking about an employer, a health system, we want to make sure we have everything we need to truly take care of your employees. Then from there, we can think about data that's important to employers. Data like, colonoscopy screening, cancer screenings, preventive screening, cancer care gaps, things like that. So we're going to work with you and to ingest the data to make it easy. Again, we have great data people. It's just the systems talk to each other. To understand who the patients are, and then from there, just feeding that data back at a regular cycle, whether that be, some employers love, like strict charts, some love, beautiful visuals, just understanding, what's going on for their employees. Obviously, it's always, HIPAA compliant. We're not digging into saying this individual person is doing this, but really showing them trends, okay? This is how many people we saw this month. These are the conditions they were seen for. These are the medications we're prescribing. These are the amount of colonoscopies we ordered. I think that's really, really critical to show that we're actually doing the work that we should be doing.
Right. And walk me through what the typical experience is like if we think about the patient experience. I know there's like navigation, advocacy aspect as well. What does that kind of look like from start to finish if my employer offers Galileo telehealth and I, want to call in and talk to a doctor? What does that look
let's
like?
walk through this. This is a fantastic piece. And if you don't mind, maybe I'll even go a step back more too. So if we're lucky enough to work with one of your employers, we're going to go ahead and really be a team on this. So, maybe not a podcast, but we're going to do things like webinars. We're going to say, welcome to Galileo. And we're going to have as many employees come on as possible. And I'm going to walk them through literally from step one. We're going to get the phone out. We're going to show you what we call the FTUX, fancy words, first time user experience. And we want to make it as simple as possible. The team we have, when we're thinking about product and engineering, they've been working with our founder, Tom Lee, for a very long time. Way back to the Hippocrates days, which is the very first handheld app on the Palm Pilot, exposing how old I am right now.
The Palm Pilot.
The Palm Pilot.
We're going way back.
So way back. So literally, the first app to show doctors, what medications don't interact well with each other. Stuff we used to have to memorize or look up in big, dusty old books. And so user experience is critical. So really, the patient enters just a little bit of demographic information, their name, their address, quickly scan their ID, and then they're essentially in the app. And then we really broke it down because we want to break down any barrier to accessing care. So there's two choices. One is basically ask us a question. of the administrative team, and that could be anything like, I got this bill in the mail, what's going on here? Or I've had trouble booking this appointment, or I'm having trouble at the pharmacy. And the second one is literally just get care. And you can go in there and just type in what's bothering you. We have all these things called intelligent intakes. So let's go back for a second. Thinking about the patient, some patients are very well versed in kind of their conditions. So they know that high blood pressure is called hypertension. Some people don't. Some people just know the names of their medications. Some people just want to type in, what's bothering them. I have a stomach ache. I have a headache. So again, making it as simple as possible. So they're going to go ahead, type that in, and just answer a few questions. That's going to come back to me as the clinician. And then I'm probably going to do one of three things. I'm either going to say, Maddison, welcome to Galileo. It's very clear what's going on for you right now. I'm sending a medication to your pharmacy because you have this going on. Or I might say, Maddison, I think what's going on, but I just have to ask a few other questions for you. I also might say, Maddison, this is a little complex. I won't say complex, but that's what I'm thinking. We might want to hop on video right now, just so I can kind of see how you look. I can see what your environment looks like. If it's say like you sprained your ankle, I can see you actually walk for me. So really, again, it comes back to the patient and making it as simple as possible for them. A little bit of demographic information, scanning ID, and answering a few questions.
You bring up a good point about the environment. And I think when you say that, I think about social determinants of health. How has that translated as far not only access, but thinking about how SDOH social determinants come in here with telemedicine?
This is the one that I'm proudest of and happiest about, because really digital medicine, telemedicine levels that playing field. We've been talking about this for a bit. But again, it now gives patients who live in areas where they don't have access to incredible clinicians, not for, just because of simple geography, and now they have access to a care system that was built for everyone, right? And so you can take patients who live in very rural areas, you can take patients who are demographics that are traditionally not well represented in medicine, socioeconomic standing. We do a lot of great work out in New Mexico in maternal health deserts, where there's like a 3-hour drive to the closest gynecologist. And so, we were seeing patients who, prior to us initiating this program, would become pregnant, and then the next time they would see a clinician was when they were giving birth. So like 9 months, and if you've had children, you're being seen, in the beginning, once every month, then towards the end, once a week, sometimes every other day, depending on what's going on. So we can provide those digital resources, connect, with midwives, and kind of really provide all that support and figure those things out. Oh, we actually have high blood pressure in month 3. Let's start treating your high blood pressure so that way when it's time for birth, there's no preeclampsia, things like that.
Yeah, and what you mentioned, working with an employer and advertising, we have this benefit. How do you get engagement from employers? Like you said, they can still keep their doctor that's down the street if they have one and they love them. But how do you really engage employees here and get them on board?
Yeah, it's a fantastic question. I think it really starts at the top. It starts with leadership. Leadership being willing to engage and actually use the platform. So many times I've had, CEOs, CMOs, just VPs of HR start using the platform. That's number one. And they have a good experience. They start telling their colleagues. Then on top of that, we mentioned this before, I love doing these webinars. So as many employees hop on as possible, we walk through it as if we're going to do a case, kind of walk through all the different scenarios, explain to them, like you said before, if you have a PCP, we'll be here to support you. Here's some ways you can use us. We go through cases where someone comes home from work and they're not feeling well late at night. We realize that their son or daughter was exposed to flu during the day. Now they have a fever and chills. We're going to start treating them for the flu. And then I've seen this just kind of organically. Once 1 or 2 employees realize that they can get the kind of care that they can get at 2 a.m. and not have to worry about finding an appointment or missing work, they're going to tell their colleagues. So it's kind of like this really organic cycle of like starting with leadership, having these engaging webinars, have people using the platform, and then our ability really to check in and continue that conversation. Because when people traditionally think of like a doctor's visit, it's that 15 minutes and then you're gone for the remainder of time. Ours is a running conversation. I think people really like that. It makes them much more likely to engage.
Yeah, and it just has evolved so much from the legacy telemedicine from even 5 years ago, pre-COVID, it's much different. How do you see, if we kind of try to look into the future, 5-10 years down the road, how do you see virtual primary care impacting the healthcare system and how we receive care?
Yeah, no, I think in 5 to 10 years, we'll see it become like up to 90% of the beginning of everything. It's really got to be the front door. Everyone should start there. If you think about how we do things right now, the concept of having, building $1 million office here, $1 million office there, it just doesn't make sense financially. It also is not very inclusive. So if you can use virtual primary care, and again, we're talking what we talked about in the beginning, virtual primary care that actually builds relationships. It's not just there for the one-offs. Of course, we're going to do a great job when you have a cold, cough, or flu, but we still need to know that other stuff because it could really influence. So one, it's going to be the front door. Everyone should be using it to start. Two, I think as we become more sophisticated with things like, remote monitoring, we'll be able to predict things even better. Kind of like, I didn't wear it today, but like my Oura Ring, things like that integrating with our practice. And then three, I think we really need to rethink the concept of the office. And we're probably going to do this as well. Really building the office of the future. It's not going to be for cold, coughs, and flus. It's not going to be for checking in on your diabetes. It's going to be for those procedures when you need a vaccine or you need to have, a wound dressed and things like that. So you change what a primary care office is and you combine it with virtual primary care at the front. And I think that's where we're going to be.
Gotcha. Yeah, I'm very excited to see where it goes and how it changes. What would you say, what are some of your favorite stories that you collected over the years, or even recently doing virtual care that you think would be helpful for people to hear?
Yeah, absolutely. And I think of this really broadly and, always coming back to, thinking about populations that in the past haven't been traditionally well represented in medicine or taken care of very well. So one of the very first things we did at Galileo was to build a Spanish language access program. If we think about the United States right now, last I checked, there's well over 100 million Spanish speakers, of 330 million people in the US. If you really dig into the numbers, they tend to have lower rates of insurance, just poor access to care. So we said, we want to build an identical program, because many places do have a Spanish program, but it's kind of buried at the bottom of the webpage. So what we went ahead and did, any content that we built it in English and we build it in Spanish at the same time, right? So that way there's really no difference in experience. So one of my favorite stories is if you think about Spanish-speaking men per se, if you look at the numbers, traditionally, you see very low rates of depression, but we know that's not true. They're actually pretty high. And because we've changed from the factor of having to come into the office, have people see you come in, sit down face to face and have that conversation, if you move to text or you move to phone, we saw a dramatic increase in Spanish-speaking men reporting anxiety and depression. And then if you look out 3 to 6 months later, dramatic decreases in their scores. They're getting better because I think they like the modality. It allows people to open up and still not be scared. It's not like we're sitting here at the podcast right now. And that's one of the greatest examples I've seen. And then two, I think the simple stories is because time is not an issue in the construct of that 7 to 12 minute visit, because it's a running conversation, people who utilize true longitudinal digital care really feel heard for the first time. So we hear constant stories of just thank you. Even if they're simple things like refilling blood pressure medication or refilling diabetes medication, the concept of the patient knows that they can get to us anytime that they want on their time and there's no rush on time. The conversation can continue over the week. Those are some of the biggest kind of simple wins.
Gotcha. What else do you think would be helpful for people to kind of think about if they've not thought about a telemedicine or kind of this virtual primary care option for their employees yet?
Yeah, I've heard many fears over the years from employers. Jason, how do you do these things if you're not physically in the same room? How do you truly understand what's going on for the patient? And I'll be honest, I worked in a brick and mortar office for 10 years. And I wanted to make the leap because I knew the power of digital medicine and I knew how it could improve access. And I knew, especially if you paired it with quality like we do, that would be great. But still, there was that fear there because we weren't face to face. And like being with me in the office was always the best thing you could possibly do. Couple thoughts though now. When you work with digital medicine, we work collaboratively. And I'll be the first to tell you, 2 brains, 3 brains, 4 brains, always better than my 1 brain. So that's one. So trust the process that the level of care and the expertise that you're going to get on the employer side is so much higher than the individual provider in the office, right? Number 2, really believe in, if you're doing this for your employees and what they need and what they want. Care being delivered on their time cannot be underrated. It really changed the game. Think about calling your own doctor's office, right? And it's not gonna put you on the spot, but like think about myself and just, worrying, can I be seen today? Can I not be seen today? Are they available? Are they open? Getting rid of that, we're open 24/7, 365, and just knowing that we're always going to be there, that should be game changing for the employers as well. And then let's dream big together. We haven't talked too much about finances. Let's create a model that works. Let's put let's do value-based care. Only pay us, if we're actually making improvements. There are ways to do this and to think differently. Let's collaborate on building programs together. Let's collaborate on building content together. There's so much more stuff you can do when you work with a digital practice than you can with a brick and mortar practice that way.
That's awesome. I think that helps just give employers something to think about when they might have in their minds traditional legacy telemedicine, and it's more that reactive cold, cough, flu kind of thing. And this is really taking it a step further and thinking about it in a holistic or preventative approach.
It totally is, but also at the same point too, we want to collaborate together. There might be an employer who's very forward thinking and wants to figure out how do we prevent the breast cancers of the world? How do we prevent the colon cancer of the world? And we can do that together. We're going to make sure your employees have all their screenings. But it also might be very important. You might have a workforce. We work with a very diverse workforces across the country. Some in trucking, some in manufacturing, all the way to super high tech, white collar workers. In some industries, something as simple as getting a work note, has to happen, and it has to happen quick, because if that person doesn't show up to work and there's no note, they're not going to get paid. And that's going to affect them and their family, and they're not going to be able to eat tomorrow. That's really important. So we can build programs that, hey, yeah, we want to focus on the longitudinal stuff, but here's a pathway where we get that note to you in 10 minutes. It's going to come through a special pathway on our side. So think about what you need and how we can build solutions together more than anything.
Yeah, I think about kind of well-being strategies when I think about that, getting people their annual exam, kind of, thinking about that. So it sounds like there's customization with how it doesn't just have to be, call when you're ready. You can kind of have a programmatic approach where
Absolutely.
You're strategizing how employees would use it.
So important. We talk about this a lot too. Thanks for reminding me and bringing it up. On those kind of welcome calls, one of the first things I tell people is, hey, let's get to know you and you get to know us. Let's do a digital annual wellness exam. So we've really pioneered that and said, hey, we're going to send you an intake. It's going to ask you all about your history, all about your family's history. Really important, all about your lifestyle, and then what kind of what kind of preventive care have you had? Do you know that the colon cancer screening age has changed from 50 to 45? Many people don't know that. So we'll go through all that. We'll have a 30-minute video visit together. At the end of it, we're going to come up with a plan together. We're going to say, Maddison, you need just these 3 labs, and you need this screening here, right there. We're going to send you out to the lab, get those labs back, and then we're going to get back on video, review those labs with you again. So again, we look at this through multiple lenses: the preventive, we look at this through the acute, and then the longitudinal and the chronic as well.
Something we haven't really talked about yet is mental health, behavioral health, which obviously is huge in healthcare and employer space as well, especially since COVID. The awareness of just mental health, how that affects your job and your output. Do you guys address that as well as part of the team approach, or what does that kind of look like?
It's such a critical point to bring up. Essentially mental health is primary care. So it's funny when we think about and like breaking up. We just took 100 cases that came into Galileo and broke them up. The actual title of 20% of them might be behavioral health, mental health, anxiety, and depression, but in reality, it's probably 90%. They're involved in everything. So let me step back for a second. We just understand, if you really think about how one's mood affects everything. Let's just say, for instance, you're a person who has high blood pressure, and I'm asking you to take a medication. I'm asking you to kind of eat differently. I'm asking you to sleep differently. I'm asking you to exercise differently. That's a lot of work in everything that's going on. And if your mood is off, those things are going to fall by the wayside just because it's hard to keep up with all of them. So we come back and say, hey, we know how this important is. We want our providers to be incredibly skilled in behavioral health. The world doesn't traditionally think of primary care doctors as incredibly skilled when it comes to behavioral health, but the reality is primary care doctors see almost all. Psychiatrists are wonderful, but they're very limited. There's many fewer. People are limited by insurance and cost and location. So when providers are applying, to a company like ours, like Galileo, we build scenarios where it might be a traditional diabetes case or a traditional blood pressure case, but I'm layering in there very subtle behavioral health clues. You didn't go see your daughter's soccer game this week. You didn't go to your son's recital. I want the provider to be able to pick that up. And like we talked about before with the diabetes example, if we're just reflexing to adding another medication or changing the medications, we're probably not going to hire you. I want you to step back and say, Maddison, is something going on right now? Here's this scale. And in those webinars, when I talk about it, I'm always saying, hey team, when you come on board, don't be weirded out when you're calling in for a cold cough or flu and I start asking you about your mood. because we know that's how that's going to affect things. Because if the underlying mood disorder is not treated, like you said before, you're not going to do all those things to manage your health. And then that's going to result in you're not going to show up to work. You're not going to want to go to work. You can't go to work. And so if we address those things so much earlier on, most importantly, the patient's feeling much better. Most importantly, they're doing all the things they need to do for their blood pressure. And also, if you think about the employer as well, you're decreasing the amount of work that's missed and you're decreasing costs as well.
Yeah, that's awesome. I don't think a lot of people do think about a primary care physician being able to identify some of those clues into anxiety and depression. At least not regularly. Maybe,
I think they
sometimes.
could, but the system is kind of built against them. Like we talked about before, if you're in a 7-minute visit and you have to just take care of the thing that they came in for, it's hard to think about them holistically.
Right. There's not as much time for
There's not as much time.
Those kind of
and
conversations.
it's really the key.
You love your job.
I do.
It's obvious. What do you love most? Like, what is like the best part of being a physician and working in this digital practice?
It's the relationships. And people might say, how do you have these relationships, if you're virtual? But they're there. It really is. Opening up that case, being privileged to be, to have someone share all these things with me over all these years and to truly open up and to be vulnerable at a time when they're not feeling well, at a time when they're sick. There might be a new diagnosis, just that privilege of sharing that with them and holding that space. And, you mentioned before, kind of like 5 to 10 years from now, one thing I forgot to mention was, as we have things like AI continue to be built into systems, humans are still going to be the most important piece. It's going to allow me and you to really build an even deeper relationship because some of the back end stuff will be handled. The prior authorizations, maybe that's an AI thing one day. But for now, it allows me to really take away the pieces of my job that are not critical and allows me really just to build that relationship with you. And to see you actually, to see a patient, it sounds so simple, but I'll give you an example. Recently, I had a patient who had pretty high cholesterol. And things like lifestyle changes weren't super high on their list. They have a busy lifestyle. They're working, trying to support the family. But they also didn't like medication as well. So we sat down, we had a nice long conversation about lifestyle change, and they did it. And we just repeated their labs 3 months later, and their cholesterol went from 250 to 175.
What did they do? What did they actually agree to do?
They actually, this is the partnership. It was with the family. The family decided to start changing how they eat together. Okay. All right. This is a person who's very sedentary, always at their desk all day, started taking 2 1-hour walks every single day. Substituted soda. As a doctor, I'll admit I have some guilty pleasures. I don't mind a Coke every once in a while, but switching from soda to water. Those simple little things can make such dramatic changes for people. And they did that. And when they saw their numbers come down, they were thrilled. And it's that joy that drives me every morning.
Gotcha. Yeah, them seeing the progress and being proud of themselves.
And then really thinking about, if you have the time, you can then really walk out for them what this means in the long run. This patient happened to be 40. So if you're decreasing cholesterol now, you're preventing what could happen at 60 and that heart attack and that all the downstream events.
Right. All right, Jason, any other closing thoughts as we wrap up here?
Yeah, thank you. Let's walk through the big picture right now. So I want to think about this from the patient's perspective and the employer's perspective. So first, as the clinician, I'm always going to start with the patient. So first and foremost, the concept of turning care back to where it should have been all along. Delivering care on the patient's time, the patient's modality. So whether that be video, text, phone, the middle of the night, the middle of the day, allowing the patient to book on their time and not my schedule. Number 2 now, from the employer perspective. Let's go ahead and think about cost for a second. We take 10 patients. They go ahead and text me on the Galileo app as opposed to showing up in the emergency room. We just had amazing cost savings, right? That's number 1. And then you can play that out through numerous other angles that we talked about, whether that be through not sending them to a specialist moving forward that we can handle on the platform, whether that be through not adding a third medication where we just focus on anxiety and depression, that focus on mood as well, which is really, really critical. Then from the employer side again, we're thinking about things like population health. Really forward-thinking employers want to go ahead and help their employees understand that they need cancer screenings, that the colon cancer screening age has moved from 50 to 45, that they need breast cancer screenings. So we're going to prevent these long-term, downstream, terrible events that are going to really disrupt the patient, really disrupt the patient's family, disrupt their employment, and then also be really, really expensive in the long run as well. So then I think big picture, patient is doing better, employer is doing better, saving money, and it's a win-win all around.
Yeah, I love it. I love it. Well, thank you so much for being here today, Jason. It was so fun to talk to you, and thanks for being on the podcast.
Thanks for having me.
Of course.